If you're a driven, active person who wants to reach and pursue a higher quality life with some ambition, then guess what? This podcast is for you. This is the Driven Athlete Podcast. What's up, y'all? It's your man, Dr. Kyle. Welcome back to the Driven Athlete Podcast. We've got a really cool guest, Dr. Gaddis, Dr. James Gaddis. Thank you for coming in, man. I know you're a busy dude from your practice, so thank you for coming in.
Dude, thanks for having me.
So tell us more about your practice, Regenix, right?
Yeah. Mm-hmm.
Where you're at and what y'all do mainly.
Yeah, so it's the practice is called Palm Beach Regenerative Sport and Spine.
Okay.
And within my practice, I offer Regenix musculoskeletal care. And Regenix is basically a network of physicians that perform essentially regenerative orthopedics. We use biologics, your own biologics like PRP, super concentrated platelets and bone marrow concentrate, and a host of other things to sort of address any sort of musculoskeletal condition from the top of your spine all the way down to the smallest bone in your toe. It's all injection-based treatments under image guidance, X-ray guidance, ultrasound guidance. Mm-hmm. And really it's more than just, injections to fix a joint or something like that. It's a different sort of approach to musculoskeletal care to address that massive gap in between conservative care, mm-hmm. which is what insurance companies like to call it, mm-hmm. And surgery. Mm-hmm. And we know now that a lot of surgeries, there are many surgeries that are absolutely necessary, and mm-hmm. there are a lot of surgeries that might not be necessary but are overutilized because of a lack of options, essentially. And we're starting to discover now that their outcomes aren't really any better than high quality or just doing nothing. Yeah. And if they can find some high quality therapy, they might do better than getting surgery. So mm-hmm. I occupy that space in between.
Yeah, cool. Yeah. So you find yourself, a lot of the treatments that y'all do, right, are enriched platelet injections, mm-hmm. right, PRP, bone marrow, mm-hmm. dense injections, right? Like you utilize the bone marrow contents. Yeah. And then stem cells?
Yes. I'll kind of start from our shopping list of things that we use.
Perfect.
From the most simple, which by the way, I forgot to answer your question earlier. So we're just down the street.
Oh, okay.
We're on Palm Beach Lakes Boulevard and Village, right next to Renegades. I don't know if you've ever been to Renegades. It's a fun place.
Yeah. Get your country dance on.
Yeah, exactly. So our sort of armamentarium of tools, from the very most simple, is prolotherapy. Prolotherapy is sort of like the godfather of regenerative orthopedics. It's just concentrated sugar water. And we use that to treat simple conditions like, tendonitis, tennis elbow, any type of ligament laxity. We can use prolotherapy as a simple option. Okay. It acts as a mild irritant to the tissue and causes proliferation of cells that are important for ligament growth and ligament health, things like fibroblasts, and it lays down a lot of collagen and so on. Okay.
So it stimulates fibroblast activity to mm-hmm. lay down new collagen by creating a little bit of irritation on purpose within the articular.
Well, within tissues, within the ligaments themselves. Okay. So let's say you have like a lax MCL and you're getting a lot of knee valgus, we'll inject it into the MCL. And it doubles in the sense that you have the proliferation because of the inflammatory reaction, but it also acts as an osmotic, meaning it's concentrated, so it kind of draws fluid out of the tissue and tightens the tissue up. There's some debate about how true that is, but you still, improve ligament health by using that. So that's our most simple option. The next most common thing we use is called super concentrated platelets, which is actually sort of one step past PRP. Okay. Meaning PRP is basically you take whole blood, you spin it down, you get rid of the red blood cells, and what you're left with is plasma full of platelets. We call it platelet-rich plasma. And that's usually about 1.5 times the concentration of the platelets that's just floating around in your blood as is, which is useful, but we take it one step further by taking that plasma and concentrating it even more. And then from there, we have like this dense pellet of just, several billion platelets. And then we can use whatever leftover plasma there is to tailor the concentration of PRP. Okay. Which is important because some tissues require higher concentrations of PRP than others. Which, by the way, let me know if I'm getting too in the weeds.
Yeah, no, I love this. Yeah.
So we're able to concentrate the SCP, super concentrated platelets, to different concentrations depending on what I'm treating. Meaning, ligaments and tendons, I can usually 5 to 7x concentrated is good. But if we're treating, let's say, a herniated disc in the lumbar spine, you need 20x. And, that requires a lot of blood to get to that 20x concentration, but it matters. So that's SCP. And then we typically use those for mild to moderate conditions and most spinal conditions.
Okay.
Beyond that, we enter into the realm of bone marrow concentrate. And that's where the word stem cell sort of fits.
Okay.
I don't like to say stem cells alone because that implies a whole nother process that is not FDA approved in the US right now. And certain facilities can do it correctly overseas and so on. But as far as what we can do in the US with your stem cells is we can get your bone marrow. Very similar to what they do in the hospital for, cancer patients and so on. They aspirate bone marrow from the pelvis, from the big iliac crest on the side there. From there, we take anywhere from 60 to 90, in some cases over 100 cc's of bone marrow, and we can concentrate that down and take specifically the white cells or the buffy coat. The buffy coat has all the stem cells essentially. So let's say out of a 90 cc bone marrow concentrate draw, I'll probably get 3 or 4 cc's of concentrated, what we call mesenchymal stromal cells. They used to be called mesenchymal stem cells. Now they're called stromal cells.
Okay.
Yeah. Think of them as like stem cells with a college degree.
Okay.
Meaning they used to be pluripotent, like they could become anything. And then because of where they are, they essentially have differentiated into some sort of musculoskeletal tissue. They're either going to turn into ligament, tendon, cartilage, bone, or muscle. And depending where you inject them, they sort of learn from their environment that you've injected them into what kind of cell to turn into.
And they follow suit. Yeah.
Exactly. So out of a 90 cc bone marrow, you get maybe 4 cc's of concentrated bone marrow cells. And then out of that 4 cc's, you might have several 100 million or a few billion stromal cells, MSCs. And within that, there's like maybe 100,000 actual true stem cells.
Okay.
Yeah, so you do have a small concentration of your true stem cells inside your bone marrow, but it's a small number.
Right.
Up until about 2009, it was possible to isolate those like few stem cells, analyze them, and then culture them, grow them out. And so then you could, expand, or what we call cultural expand, those stem cells to like several billion. And now you could store them and have them for later. But in 2009, the FDA ruled that was called more than minimal manipulation. There's basically these laws surrounding what you can do with human tissue. And minimal manipulation is one of these. So basically you can't change the chemical properties or grow things or without it being considered a new drug. And a new drug requires phase 1, 2, 3 FDA trials. It's a several billion-dollar industry. Yeah. So those facilities that were able to do that sort of moved offshore. For example, Regenerative has a university-style lab in the Grand Cayman Islands where they do this. They basically culture your stem cells, expand them, store them so you can use them for years and years and years later. As soon as I get the chance, I'm going to go out there and do that before I turn 40. Get some pre-40 stem cells.
Yeah.
But going back to the U.S. and what I do essentially in clinic is we isolate bone marrow, we concentrate it down, and then from that we can inject that back into more severe arthritic conditions like bone-on-bone arthritis is a commonly used one, bone death, avascular necrosis of the hip, things like that. We can inject it into the bone, and it essentially halts the progression of arthritis. Yeah, pretty good success rates. Yeah.
That's really cool. That's awesome. For SCP, super condensed platelets.
Super concentrated platelets. Close enough.
Yeah. For herniated discs. And then I was also going to ask about tendinosis, like maybe a golfer's or tennis elbow or something like that. Is there super common, like what they call like recalcitrant development or progress for like healing? What's for herniated discs? What's the mechanism?
So it depends on what kind of disc you're treating. So let's say a disc has a little tear in the outside of the disc, an annular tear. We know that if you just pump that disc full of super concentrated platelets, they might just leak out of that tear. So what you have to do is decide, okay, where is this tear and what's the best way for me to approach it? Because you really want to put those platelets right in that tear. Because those platelets will stick and aggregate, and then they sort of open up from there. So let's say you have a disc tear that's sort of out laterally on the side. It actually makes more sense not to even go into the disc, but to just, with the needle under x-ray guidance, just go right up to that little tear and park the needle right in front of the tear and deposit your platelets there. Very few cc's. If you're dealing with a disc that's a little bit more degenerated or is, bulging, then it makes more sense to sort of go into the disc itself. And from there, you have to sort of decide first, is this the disc that's bothering the person? Because usually there's more than one disc.
Yeah.
So you do what's called a discogram. So we basically guide the needle in there. The patient is awake. And we inject a small volume of a combination of antibiotics and contrast. Contrast agent basically shows up dark on an x-ray so we can see it. And we try and provoke that disc. We fill it up a little bit. And then we ask the patient, does that reproduce the same pain that you have? And a lot of times they'll say, no, that's something different. And so you sort of have to look, and maybe it's not the disc that you expected. Maybe it's a different one. So
interesting.
Course correct. Once you sort of reproduce that pain, then that's when we inject about, 3 to 4 cc's, depending on the disc, of that highly concentrated PRP. And it has your white blood cells in it. So we call it leukocyte-rich PRP.
Gotcha.
And that's more of a protective factor because the discs are, they're prone to getting infected. There's oftentimes they're colonized with a certain type of bacteria. And so you want to have your white blood cells in there to sort of, manage that party.
Right. Yeah, totally.
So again, it really depends on the disc. If you're dealing with an annular tear, which is usually the most painful, you want to get as close to that tear as possible. There is a device by the late, great Dr. Greg Lutz, who recently passed away. It's like a catheter that basically kind of curves around. So you enter the disc and then you introduce this catheter. It curves around and you can direct it right to that little tear. And you just deposit your platelets right there.
Interesting.
Which is amazing. It's an amazing device. Or you just fill up the disc itself. Yeah.
Interesting. And then the platelets will be in there. They'll aggregate, proliferate, and then help scar down and heal up the tear.
Essentially. Yeah. That's the goal. So there's a lot of studies that show that the more that degenerated the disc is, the more likely those platelets are just going to immediately leak out. So if you have a completely desiccated or degenerated disc, then you sort of have to decide, is it worth injecting the disc and putting the patient at that risk? Or do you want to do a more aggressive treatment and use culture expanded stem cells, which those have been shown to improve very degenerated and desiccated discs because they have these receptors on them called CD19 receptors that they stick to whatever surface that they're injected on. They stick within like 3 minutes.
Cool.
Yeah.
So a lot better stick rate.
A lot better stick rate. Yeah, exactly.
And for a patient like that, how many rounds of those injections, let's say it's like a very degenerative disc and they're having referred pain, right? Back pain.
Yeah.
They got an image, looks bad. Do this, right? How many rounds of that?
So,
and then re-image like in 6 months and they'd see an improvement, or 8 months.
Oftentimes we will let re-imaging, let the patient decide if they want re-imaging or not, because we don't typically, it's definitely nice to have somebody come back with a post-injection MRI and it looks beautiful, regenerated.
See, everybody look.
Exactly. But more often than not, the disc will look exactly the same on the MRI. You might have some, slight resolution of some tears and whatnot, which we can see. We actually published a study on this out in Colorado where we did pre and post MRI studies of intradiscal injections of annular tears. And it required a lot of sort of MRI software programming to be able to determine the grayscale difference on these different discs. But anyways, sometimes you'll get image resolution of the disc. That's always good. But more often than not, the patient's symptoms will improve and their disc looks exactly the same. You don't want to go into the disc that often. It is a risky procedure.
So the disc looks very, very similar. But their symptoms are a lot better.
Most often that's the case.
Interesting.
But sometimes you get this beautiful post-injection MRI where the bulge is resolved and the annular tear is resolved.
So if that looks the same, what are your thoughts on what was the symptom reduction from?
A lot of times it's leakage of the inner contents of the disc. That has a lot of inflammatory cytokines in it. There's a nerve that sort of encompasses the disc called the sinovertebral nerve. You don't see that nerve in like neurology textbooks. It's hilarious. You just kind of skip over that and find out about it later. So you can definitely have irritation of that sinovertebral nerve because of the inflammatory cytokines that leak out of a degenerated disc.
Right.
And oftentimes those same inflammatory cytokines can irritate the nerve roots. And that's where you get not radiculopathy, meaning like, down symptoms of a nerve, but you get radiculitis, so hypersensitivity, so pain and sort of tingling and things like that. So that tells me that, there's something's irritating the nerve, but not compressing the nerve necessarily. Gotcha. So by injecting platelets, you're hopefully stopping that leakage and reducing that inflammatory reaction to the nerves.
Right, totally. Yeah. And then with tendinosis, right, degenerative tendon progressions, do you do a lot with that too?
Yeah, that's like our bread and butter. Yeah. Golfer's elbow, tennis elbow, a lot Achilles. Of ankle stuff, a lot of Achilles. And Achilles, you can do some pretty cool stuff. But basically, a lot of times an MRI, you get somebody with tennis elbow, we'll look at an MRI, and if there's no obvious tear there, it doesn't really tell me 100% that there's no tear. So oftentimes when we're treating with PRP, I will sort of explore with the needle, meaning I'll introduce the needle into the tendon and I'll gently test with some pressure. And if there's resistance, then I know that is an intact tendon. There's no tear there. But sometimes you put a little volume of fluid and a tear that it was hiding now all of a sudden opens up. You could see it hiding inside. You would have never seen that on an MRI. And so we'll sort of, when you see that, you want to like fenestrate the tendon. You want to increase the surface area of that tear so that these platelets can aggregate, open, and do their magic. Yeah.
Interesting.
Yeah.
That's really cool. I mean, chronic lingering tennis elbow and golfer's elbow. It's like I've battled that recently, like over the last maybe 10 months, probably maybe 8 months.
Oh yeah.
Just lingering. Yeah. I'll needle myself, like dry needling myself and stuff. But man, it's annoying.
It is.
A lingering tennis elbow or Achilles tendonitis. Like a lot of patients stumped. You know what I mean?
Yeah.
That's good though.
One thing that I would add to that is, when somebody has a chronic tendon issue, it's worth looking outside the tendon. You've got to wonder why. Like, why is this guy having this recurring tendon issue?
Right. Exactly.
And so a lot of times, especially with people who have, let's say tennis elbow or golfer's elbow, I'll look upstream. I'll look at the shoulder mechanics. I'll see if their arm tends to be pronated. I'll look at any cervical issues. There might be a subclinical radiculitis there. If they're having golfer's elbow, well, that's your sort of T1 dermatome. So I'm looking at C8, T1 nerve roots to see if there's any issues there. Is there any forward head position? Is there any irritation of the facet joints in that area?
Yeah, totally.
So I'll likely treat that whole kinetic chain. So we'll do platelet epidurals at those levels. We'll treat the ligaments. We'll treat the joints. And then we'll treat wherever the actual tendinosis is.
Sure. That's awesome. I think something that separates like a person like yourself in orthopedics, you know what I mean? And unlike, that's what, of course, like as a sports physical therapist, like we're not going to do PRP injections. Although dry needling can be helpful, totally. But anyway, we definitely, like when we got to look at the scapula, and the shoulder. Because like if I've always under the impression some mentors described it like a tendon at this point is the victim. If it's overwhelmed and like chronically a tendinitis problem, you know what I mean? Mm-hmm. It's like usually it's because that thing is a victim and it's overworked and over-required because of compensation issues elsewhere. And especially like a full body movement like like a tennis player, right? Or even golf, right? There's got to be other compensations elsewhere that's maybe like what's leading to the tendon getting lit up and overwhelmed in the first place. Like we have to address those things. And then that'll actually follow suit versus like just treating the tendon like at this it's just a tertiary problem. You know what I mean?
It's a very like kind of binoculars view.
Exactly.
Which
totally.
is honestly that exactly right there is why I left pain management, because I was in pain management initially and I was like, I need something more. Like we're missing something.
I was gonna ask. So tell us more. All right, a little more background story. Originally, where are you from? And then where'd you go to med school? And I know you were in Colorado doing a lot of neuro research, right?
Yeah, so I like long walks on the beach. No,
Yeah.
Yeah. My folks are actually from Egypt, first generation American. So I grew up in like the woods in Georgia.
Okay. Where in Georgia?
Marietta, like outside of Atlanta.
Okay.
Yeah.
Because we took as a family Thanksgiving trips up in northern Georgia.
Oh, nice.
Like Blue Ridge Mountains area.
Yeah.
Yeah. So we passed through Atlanta and go to like Helen or we went to Dahlonega.
Dahlonega, yeah. They got one of the roller coasters at Six Flags up there is called the Dahlonega Mine Train.
Oh, really? That's cool.
Yeah. I would advise no one to go on it. It's so rough, like you're gonna leave with neck problems.
Yeah. Hey, take my card on the way out. I need some PRP injections. Well, that's cool. No, we love it up there, man. We want it's beautiful.
Yeah, beautiful forest. Grew up there, moved down to Fort Lauderdale in like 2003, and then I went to high school, Pompano Beach High School. And it's actually there where I had a AP biology teacher she was the one who sort of got me on the medicine track.
Cool.
So she was a biology teacher.
What was her name?
Dr. Singh Conrad.
Okay.
If she's out there,
shout out.
Yeah, exactly.
You are the reason.
Singh Conrad. Yeah. She was great. And
that's cool.
I didn't know this at the time, but her husband was a DO.
Okay.
And I didn't know what a DO was. I was like 15. And she would show us all these cool techniques and these philosophies and all this stuff. And I was just so intrigued that from that point, I sort of decided, okay, I'm going to do this whole like medicine thing. And, it was a long and crazy road with college and all that stuff. So graduated high school, went to the University of Florida, go Gaddis, and got accepted into Lake Erie College of Osteopathic Medicine. And before I did that, I actually worked for a year down in Miami doing research at a neurology clinic. We were researching Botox injections for upper and lower limb spasticity for TBI and post-stroke patients. It was like 11 simultaneous clinical trials. It was crazy.
Wow.
Yeah. But I learned a lot, and I saw that, and I was like, okay, neurology sort of is on my radar. Went to med school, did the whole first, second year, step 1, step 2, just madness.
It's insane.
Yeah. And then in that process, I sort of decided I was actually really half and half between PM&R, doing physical medicine rehab, and neurology. And I just I was very undecided. And if you asked me to do it again, I would still like have a hard time deciding which one. But I ended up going to neurology because I really enjoyed neuroanatomy. So I matched into a neurology residency. I went to University of South Florida in Tampa. And there, it was bread and butter neurology, stroke, epilepsy, dementia, movement disorders, Parkinson's, things like that. I was fortunate enough to go to a program that was very musculoskeletal focused, and we had a pain management program in the neurology department.
Cool.
There's only one of 2 in the country that do that.
Yeah, really cool.
So went on to do pain management. So I graduated that residency, did a pain management fellowship, worked in pain management for about a year, like in private practice, and quickly realized, I was like, I don't know if I, feel good about, doing this for 40 more years or however many more years I would work, because
right.
it was very dictated by insurance. You were either strictly doing med management, and we all know what's, all the stuff surrounding med management, pain management, or you're doing just a lot of corticosteroid injections, and we all know that steroids are highly toxic to not only the tissue that you're injecting, but like everything else in your body. Or you're kind of being pushed to these really higher level procedures like spinal cord stimulators and these like minimally invasive fusion devices that kind of hedge on pseudo surgery. And I just thought, let me see if I can find something different.
Yeah.
And that's when I reached out to Regenerative out in Colorado. I'd actually been following them for like several years. And decided, now's my chance. So I reached out to them, inquired, like, how do I learn this stuff, blah, blah, blah. And they were like, well, we have a fellowship out here. And I said, get out of here.
Sweet, yeah.
So, I decided I wasn't married, I don't have kids. I could afford to live in Colorado
Time
for
to
a
do
year.
it.
Yeah, let's go. So
just pick up and go.
Signed up, they offered me the position, which I discovered later was like, not that easy to get. And I had no clue, which was kind of nice.
Cool.
Went to Colorado for a year, and I learned everything about regenerative orthopedics, and I learned all these, like just the amount of procedural skill that came in with that fellowship was absolutely incredible. I felt like I learned more in that year than I did for like the previous 4 years. It was crazy.
Cool.
Yeah. Highly recommend if anybody, physicians out there, fellows, residents that are interested in pain management, sports medicine, musculoskeletal care, check them out. Centeno Schultz Clinic. They have a fellowship. They 1 to 2 fellows a year. Very worth it. Very worth it.
Yeah. That's awesome. Real quick, corticosteroid injections, super common, handed out like candy.
Yeah.
What are your thoughts?
So in that year that I worked pain management, which was only like 9 months, I counted it, rough estimate. I think I injected somewhere on the order of like 500 grams of corticosteroids into patients. It's a lot of steroids. Yeah. And so, basically with every steroid injection, it, doubles your risk of getting avascular necrosis. It increases your risk of osteoporosis. We all know it messes up your metabolism, blood sugar. It suppresses the hormone axis or your pituitary axis, ruins your sleep. The list goes on. I mean, it's a miracle drug. We used to use very, very high doses of steroids in neurology for people who had multiple sclerosis and NMO and all these devastating neurologic diseases. But outside of that, it's overkill. Routinely we would inject, 4 or 10 milligrams of dexamethasone into a patient. And to give you some perspective, we naturally produce these chemicals. We naturally produce corticosteroids. But if our body's natural amount of steroids was about the height of, let's say, a matchbook, the amount of steroids that we give in your typical just knee injection is the height of the Empire State Building. It's a massive difference. Yeah. And so as you can imagine,
I had no idea.
Yeah, it's a huge difference. It's about 6 million times the dose.
Oh my gosh. A matchbook?
Yeah.
I thought you were going to say like the ceiling. I'd be like, what? The Empire State Building?
Yeah.
Holy smokes.
And so basically with repeated injections, you're just completely eliminating any possibility that musculoskeletal tissue is going to ever regenerate on its own. You're just
it just helps to stimulate degenerative changes in articular cartilage and then the surrounding soft tissue, musculotendinous junction. I've heard, and you tell me what your thoughts on this, you have like 1 or 2 free tokens.
Yeah.
And you're good, and it's fine. Not a big deal.
The old idiom is like you don't want more than 3 in a year.
Per year.
Per year. But that's also somewhat dictated by what insurance will reimburse. They're not going to reimburse more than 20.
I also imagine let's say somebody's experiencing moderate knee discomfort at the age of 42. 2 a year until they're 80. You know what I mean?
Yeah, that's
kind of a lot.
Yeah. And think about patients that come in their mid to late 30s for a steroid injection, and now in their mind, okay, that's the fix.
Yeah, got it, perfect.
And so cumulatively over the years, they're going to get a lot of steroid. A lot of things happen in addition, like you were saying, all the hormonal especially too. There's been plenty of patients that I've talked with in the past, like in passing and other workshops or seminars and things. And they're like, I just, I get, at the beginning of the season, I'll get an injection. Before I leave, I'll get an injection. And it helps maintain where I'm at and manages my, knee pain, my back pain. I'm good. Yeah. Now, by all means,
I'm like, I don't want to live like that. That's just me. But
yeah. Now, there's definitely instances in which like a steroid injection is, somebody comes in with acute, discogenic pain. They got a bulging disc.
I don't hate it.
If you put platelets there, they're going to flare up like 10 times much. So sometimes steroid injections are indicated.
Totally.
But there's always a but. You still don't really need to use that high of a dose. For instance, in our clinic, we use, I call it low dose dexamethasone. It's about 1/millionth of the dose of your standard injection.
1 million.
1 million. 1 million.
Yeah.
It's 400 nanograms as opposed to milligrams. So nanograms is like 10 to the negative 6, I think.
Yeah.
And we use that because that's a lot closer to your physiologic level. If you place that directly next to what you're trying to treat, then you're going to have the right amount of anti-inflammatory reaction. The volume of the fluid sort of pushes away those inflammatory cytokines. And there's a study out of England, I believe, that showed that these physiologic doses of corticosteroids actually promote tenocyte and synoviocyte proliferation. So it's like, oh, okay, well, you're getting kind of the best of both worlds.
Yeah.
So
I would say, I assume the synovium for synovial fluid, is that what you're talking about?
Yeah. So look, these are the cells that make up the joint capsule, and then they line the inside of the joint capsule, and they make synovial fluid.
Yeah, got it. It's pretty. That's awesome.
Yeah.
Okay, sorry. Continue where we were at. We were talking about. Oh man, I forgot the train of thought. Before I brought up the corticosteroid question.
Oh, what were we talking about?
That you were at, you finished up your fellowship. Oh, this
guy.
Oh,
yeah. Okay, yeah.
Finished up your fellowship. It was a 1-year fellowship.
1-year fellowship.
And then that's when you moved back
here. Yeah. Okay. So, there was a lot of decision-making process in that. While I was in that fellowship, I was trying to figure out, okay, what's my next move? What do I do? Yeah. I had I actually had some really, really good opportunities to work with some like amazing doctors. People that I looked up to for years. And he's actually out in Sarasota. He's got some locations in Sarasota and Tampa. But at the same time, I'd been away from South Florida since 2008. And, I was just kind of felt like I needed to get closer to my family again. At the same time, my fiance, she had the same feeling. She's like, well, it's been a long time. Let's move back to family. So my folks live down in Fort Lauderdale, and her folks live her mom lives in Jupiter.
Oh, nice.
And so we sort of split the difference and moved to West Palm.
Yeah.
And I was like, I spoke to my older brother, and I spoke to a lot of people that I really look up to about, hey, what do you think about opening up a practice and taking the leap,
Totally.
And you just at some point you got to just
gotta
close your eyes and do it.
Yeah. Pull the trigger and ride a bullet.
Yeah, and it's
calculated.
Exactly. It's been a roller coaster, man.
Awesome.
I mean, I moved down here in January, and opened up like 4 weeks ago. So that 6 months of just that grueling startup process, but I learned a lot. You look back, you're like, oh wow, I really did quite a bit to get this thing open.
Man, entrepreneurship. I love entrepreneurship stuff. Like, I'm a nerd when it comes to that.
I mean, you're a perfect example.
Totally reinvigorated my career and like just outlook on life and perspective. I'm like, this makes sense. You know?
Exactly.
Okay, so tell me about these books.
All right, so those books are authored by a doctor named Chris Centeno, and he basically, him and his partners sort of started experimenting with orthobiologics for orthopedic problems back in like the early 2000s.
Okay.
And they were the first ones to do culture expanded stem cells into vertebral discs and show improvement. So they were kind of like the godfathers of this, more or less. There's definitely people that precede them. And so Dr. Centeno sort of put these books together as a manual for patients. But it does get a little bit in depth. So it's not like...
For the right person to be cool and invigorating.
Yeah, it's a medium read. It's not a light read.
Okay.
But basically, what we do is we go through our diagnostic method, which is called the SANS method. SANS stands for symmetry, articulation, neuromuscular connection, and stability. And so we evaluate all those things when we're addressing a problem. So we talk about the SANS method in there. We talk about the differences in, the types of orthobiologics that we offer, the differences in what we offer and what is commonly found out just in the industry or just wherever, PRP that you can get or stem cells that you get in Mexico and things like that. So a lot of distinction there. And then we break it down into the different books. Basically, as you can see, there's Shoulder 2.0. This is how we approach shoulder issues.
Yeah, if y'all can't see, we got Shoulder 2.0, how you can avoid invasive shoulder surgery. Orthopedics 2.0, which I imagine is like a...
Yeah, that's like the encompassing,
How to avoid back pain, the Spine Owner's Manual.
Spine Owner's Manual, yeah.
And then how to avoid game-changing invasive knee surgeries to stay active as you age, the Knee Owner's Manual.
The Knee Owner's Manual, yeah. We have Ankle Owner's Manual and elbow and all the fun stuff.
That's great.
Yeah. They're all online,
I own
by
an
the
ankle.
way.
I own a shoulder.
I got two of them.
This is applicable, yeah. Cool. No, I have to read. That's really cool to read them.
They're all online for free, downloadable on my website.
I think a really cool thing is like, it seems like ultimately, right, our perspectives and beliefs shape our world and like what we are, the lens in which we perceive everything. But as a biased conservative therapist, you know what I mean? Yeah. It seems like medicine's going this route, less allopathic, and like if someone decides that they want the awareness of like, is there other methods besides just allopathic? Take this med, you're good for life. Take Synthroid for your hypothyroidism, you're good forever. It's like, is there an option? Like, what is this? I was just told, but is there another way, right? Or like type 2 diabetes, right? Totally reversible, right? And also joint pain, orthopedics, huge one, huge industry. Yeah. But anyway, it seems like it's going that route, which is really cool, and I love it. I think it's really interesting.
Yeah, I think patients are sort of waking up to the fact that what your insurance company tells you to do is not necessarily your only option.
Yeah.
And there are a lot of really smart minds out there, and there are a lot of, there's a lot of data coming out supporting all this. So it's definitely worth.
It's interesting.
I will say this. I don't know how much time we have, but I'll say this. Buyer beware. Because this isn't, FDA approved, it is FDA regulated, but it's not FDA approved, which means that people can offer whatever they want. And, oftentimes they make a lot of claims, and those claims sometimes, I shouldn't say most of the time, but those claims can basically be based on nothing. And so you might find yourself paying thousands and thousands of dollars for some miracle stem cell treatment, but in reality, we don't really know what you're getting.
Interesting. Just like supplements.
Yeah. So I would always say, if you're interested in, non-surgical orthopedics or regenerative orthopedics, there's 4 questions you should be asking. Number 1 is, where is this product coming from, right? Is it coming from you, or is it coming off the shelf? So it should be coming from you. Anything that's coming off the shelf essentially had to have gone through some sort of sterilizing or processing process, which means that there's no living cells in there. And we've proven that time and time again. There's no such thing as living stem cells in one of these like off-the-shelf umbilical cord, placental, Wharton's jelly stem cells. But they're not useless. I mean, they still have good growth factors in them, so they have about the same effect as like PRP, essentially. So where is it coming from? It should be coming from you. Number 2, what is it being injected into? Are they just doing a blind injection into the joint and hoping that it miraculously fixes your joints? Probably not the best. You need to evaluate the entire kinetic chain. Right. You need to look at all the different structures. You need to look at ligament, tendon, meniscus. You need to look at the neuromuscular connection. You need to look at upstream issues. So that's important. Number 2, what's the dose? The majority of your sort of off-the-shelf kind of bedside PRP kits will only concentrate your PRP to like maybe twice, which barely meets the actual definition of PRP. So it's important that you get the right concentration because it matters what you're injecting. It also matters depending on the age. So the older you get, the higher concentration you need, essentially. And number 4 is who is injecting it. There are a lot of very skilled nurse practitioners and medical assistants and things like that out there. But in order to provide the level of treatment or level of injection that I would offer, you need to be a board certified physician, having gone through fellowship training. I went through 2 different fellowships to get to where I'm at. So
there's a different skill level.
Yeah, and you got to know all the risks that go along with what you're doing, and you got to know how to mitigate potential complications and disasters. You got to know how this fits in with a lot of other medical disorders. It's not a one-size-all treatment, and not everybody can just go get a bone marrow aspiration or draw 60 tubes of blood and so on. So you definitely need a medical professional behind it.
Interesting. Yeah, that's a good point. When you arrived here, you're talking about a patient that you just had that was super interesting, right?
Yeah.
Tell us about what was going on.
Yeah, so
HIPAA compliant, of course.
So de-identified. So she, middle-aged, very active. She's a distance runner. Her favorite activity is to go run for like 15 plus miles, which that's impressive.
Cool. Yeah. I think it was interesting is like, it seems like healthcare, practitioners like ourselves, we hear that story and immediately, at least my head's like, awesome.
Yeah, I get excited.
Versus like, all right, well, you're battling knee and hip pain. Maybe you should stop running because it's bad for you.
Yeah.
It's like people like that are tired of going to people that are like, just don't do that anymore.
Yeah.
Why don't you just rest, ice, and take Advil? Like, problem solved.
Oh, Advil. Don't get me started on Advil.
We're like, man, like, what about like, how can we enable this? There has to be something going on. And like longevity-wise, how can we enable and empower this person to like continue what they're doing? And what strategies and stuff can we implement to allow this? That's high five. And assist versus like resist and then just tell them to stop.
Just like, it hurts. Oh, don't do that.
Yeah, problem solved.
Yeah.
Oh my gosh.
Yeah, I mean,
anyway,
that's a conversation I have with a lot of patients. It's like, there's no cure for arthritis, and we're not going to fix or cure the issue. But the goal here is to give your body the tools it needs to sort of get you back to whatever it is you were doing, and simultaneously try to address what it was that got you there. For example, I never do injections without also making sure that person is getting high quality physical therapy. Never. Because I can inject all I want, but unless the body is being taught how to avoid that injury again or the tissue is actually getting the physical stimulus in order to know how to heal. It's not really gonna come back. You're not gonna get the best results. So you have to couple both of them.
Cool. Okay, so lady coming in.
Lady coming in.
Endurance runner
decides to change up her cadence or her stride one day, and like halfway through her run, just intense anterior hip pain and groin pain, like searing groin pain. And ever since then, she's had sitting intolerance. She gets a lot of pain with internal rotation and flexion. Even with external rotation, she started to get some kind of adductor type pain.
So hip impingement. Underlying FAI probably, right?
Somewhat, yeah. And she came to my clinic, and we looked over her x-rays, and she actually has like grade 3 arthritis. It was like pretty advanced. But which goes to show you, she was like asymptomatic all the way up to this point. She
super interesting, right?
Yeah. So we did a physical exam. Sure enough, she had all the FAI symptoms. She also had some, pain over the greater trochanteric bursa, where all the glute muscles attach. She was having some decreased multifidus activation on the back. Her pelvis was slightly posteriorly rotated on the right and sort of outflared, and so she had some psoas tightness on that right side as well. She had that. I
love that, because like that's total. The SIJ is super involved.
Exactly.
You know what I mean? Anyway, sorry.
Through the ultrasound on, I always ultrasound exam. It's an extension of my physical exam. So I put the ultrasound on, and I was able to see that she had some bowing of the hip capsule, which made me think that there's an effusion in there. She had some degeneration of the anterior and superior labrum. Some tendinopathy of the glute tendons at the GTB. She had some tendinopathy at the iliac crest, and then what else was there? She had a little bit of hamstring tendinopathy as well, and then she had this big old bursa of fluid underneath her psoas. So there's definitely some irritation of the psoas as it's going over the anterior hip there. Worked her up, and then got her in for treatment, which was today, actually, right before I came in. And basically we did 10x concentrated platelets intra-articular into the hip. And then we did 7x concentrated platelets into the anterior and posterior hip capsule, into the anterior and superior labrum. And then we use what's called PL Prolo, or platelet lysate in prolotherapy. Basically, we take PRP, or super concentrated platelets, we freeze them, we break open the platelets, we pass them through a 200 micron filter, and we get all the goodies without the thrombotic platelet factors. And then we take that and we mix it with Prolo. So you're basically taking prolotherapy and supercharging it with all the nutrients and growth factors from platelets.
Yeah, that's really interesting.
Yeah. Take that and we inject that into I inject that into the SI ligaments, sacrotuberous, sacrospinous ligaments, and then under fluoro, I did platelet lysate injections of the iliolumbar ligaments, interspinous ligaments at L5 and S1, and then a transforaminal platelet epidural at S1 as well. So really just addressing that whole kinetic chain, that whole
lumbar down
there.
to hip.
Lumbar, and then I'm actually sending her to you guys.
Cool. Well, we'd love to help her.
Yeah.
Because endurance. It's interesting. They're a different breed, and like we love working with endurance athletes because they're in the same boat of like, no, this is what I do. Like, no, this is what I do.
Yeah, exactly.
Awesome. Let's get it. You know? But that enthusiasm and buy-in always just helps outcomes.
Yeah.
Why not do the PRP injections like that all the time to avoid the thrombotic properties like you were describing? Thrombotic being like, you want to describe thrombosis like?
Yeah. So basically, platelets, they like to clot. That's their main job. They basically stick and then they break open. And in some cases, like if I'm injecting into the epidural space or into the spinal column, I don't want there to be any sort of risk of clot. It's a theoretical risk, but it's a risk nonetheless.
Yeah.
So we basically take those platelets, concentrate them, break them open, and then filter out the goodies. So we use platelet lysate in the spine just to reduce the risk of thrombosis or clotting. But for like ligaments, I could inject platelets in there and you still get a good response. But sometimes you want to use prolotherapy. And so I'm just essentially combining them.
Yeah.
And so if you take Prolo, which is just dextrose, sugar water, and then you combine it with PRP, what happens is that because the sugar is so concentrated, the dextrose is concentrated, it basically turns the platelets into like raisins. And so they become dysfunctional, they can't stick, and they can't open up. So you're basically destroying the PRP. But if you just get rid of the platelet part and you take all the factors, the nutrients from inside, you can mix that with prolotherapy, and there's no issue at all, basically. So what that does is that lets me sort of volume expand, meaning I can treat more structures without having to take so much more blood from the patient.
Yeah. So combine the prolotherapy with that. It's the prolotherapy small purposeful irritation of the joint, of the structure. Platelets in there as the heroes to go in and solve the problem. Yeah,
basically you're giving them all the nutrients they need to sort of regenerate.
Cool. That's really interesting, man. That's awesome. Well, I love that. We'd love to help her. See a lot of runners and stuff.
Yeah.
Cool, man. Well, I appreciate that. So, all right, last question. What would you say is like your wheelhouse?
My wheelhouse.
Ideal patient. You guys crush home runs with these people.
Every patient's an ideal patient.
Yeah. I mean, honestly, like I feel the same way of like, it doesn't matter if they're just motivated and enthusiastic and they're ready to want to see good outcomes and results.
Yeah, the fact that they're coming to me means that they're in the mindset of I want to get better, not just fix this and let me get back to my life. So my wheelhouse, I would say, spinal conditions, especially like cervical spine, so neck pain, headaches, shoulders, jaw pain, TMJ, things like that. I love doing that, and that's partially because of my neurology.
I was gonna say that's it's a cool link.
Yeah, right. So I mean, a lot of like. When I was in residency, I mean, it was always just migraine until proven otherwise. And now I'm discovering, there's more to it than this. Yeah. Yes, you can have migrainous features, but we need to be looking at the neck, because if there's any sort of instability, if there's forward head, if there's loss of the curve of the neck, like you're going to get neurological
cervicogenic headaches.
Yeah, absolutely.
TMJ referral, totally. We've been seeing some more at TMJ patients, which is interesting.
What do you do for TMJ patients?
Mobilize internal mobs.
Yeah.
And if it's hypermobile or hypomobile either side, and then dry needling is really effective into the joint, underneath in the joint.
Yeah.
The lateral pterygoid, masseter, and then the temporalis muscles.
How do you get to the lateral pterygoids? That's
through the
deep.
joint. Yeah, I know. Yeah, it's kind of scary. You go through the temple, like through the sphenoid region.
Yeah.
And then just below the condyle. And then
so
straight
you're going
through.
Like through the mouth, or how are you getting to that?
Right here, straight through. Take like a 1-inch needle.
Nice.
Yeah. Usually we use like the I think they're 15 millimeter length needles for the masseter, the temporalis, and then the joint itself, intra-articular.
Yeah.
But then for the lateral pterygoid to reach it, you gotta get like a 1-inch needle and go straight through.
That's hardcore.
Yeah.
I like it.
But it's interesting is like, it really doesn't feel like, people get freaked out, they're so tiny, you know what I mean?
Yeah.
Like the needles, but it's really effective.
Yeah. That's awesome.
Yeah.
Okay. Good
and
to
you
know.
can put the stimulation on it too.
Yeah. I have a very good friend who she has bad, bruxism. She grinds like crazy, and her masseters are just like rock solid.
Yeah. Totally.
And so I was trying to figure out, what do I do before we put Botox in there, basically.
Yeah.
Which actually, that reminds me, anyone who's getting like Botox for migraines, the typical protocol for migraine Botox is to, obviously inject around the head, but they also inject into the neck muscles. And that can actually cause a lot of problems down the road, because by weakening those, by weakening that posterior chain, you get this.
Pretty more instability.
Yeah. So, I decided that, when I treat my migraine patients with Botox, that I'm going to do the typical, cranial injections, but just avoid the posterior neck.
Like we usually, from our head, we don't do injections, right? It's not our thing. But for fixing headaches, it's like, how can we help improve this? We definitely consider upper cervical, suboccipital, cervicogenic headaches. TMJ is definitely on the list too.
Yep.
And then not our realm, right? But if someone's bruxing at night, clenching, clearly there's some kind of anxiety. We can't neglect. There's a psychological component to a pain experience. You can't separate the mind from the body, but that's also something that we can't neglect, and be like, that's something I would dive into, right? Not me, but like, that's something I would investigate on your end. And I do have some mental health professionals that would recommend totally.
Nice.
But that's something that I'm like, we can't neglect that either. You know what I mean?
Yeah.
It's a delicate dance of a conversation. Of course, we're not, we want to validate and do the things that we can, but then also, hey, we can't separate the mind from the body or neglect. There's a psychological component to pain too something I don't want to leave any stone unturned, you know.
Having those resources is like invaluable to be able to recognize, okay, there is a significant sort of psychosocial component to this. We need to address
the biopsychosocial model, you know.
Exactly. So to be able to send them out is good.
It's not what we do. Yeah. Well, I want to help you with,
but I know somebody who does
biomechanics, pain for sure. You know, strengthening stuff. But I do know people that do, and like, you know, if you're interested, we'll reach out, you know, or we'll give you the information if you want, you know. Yeah. But anyway, sorry. Go ahead. Migraines. Botox. So basically, if I do, you know, Botox for migraines, I treat, you know, appropriately, but I just avoid the posterior cervical chain because it might help your migraines, but you're going to eventually get cervical problems and maybe cervicogenic headaches down the road. It's an important thing. Yeah, totally.
Yeah. But other than that, I mean, going back to the wheelhouse, like, you know, my favorite thing is treating spine. I love being with the C-arm fluoroscopy, just hitting facets, transforaminal, getting the ligaments, multifidus, just getting the whole functional spinal unit, which, man, I could talk about functional spinal unit for like hours.
Functional spinal unit. This is
amazing.
Exactly.
And then, so that's like my favorite. My least favorite is ankles. Ankles are tough. They're very tough. Very tough. They're hard to, I mean, they're very painful when they're in pain. Anatomically, they can be very, very challenging.
Yeah.
But if you get it right, if you get it right, you can really change someone's life.
Cool. Yeah, a lot of moving parts. You know?
Oh yeah. A lot of force, like a lot of weight and tension, and you know, it's a very tough joint.
Yeah, totally. All right, man. Well, dude, thanks for coming in. We'll have to do another round.
I'm down the street, man. Just let me know.
Talk about all the other stuff we can nerd out on, you know, which is cool. Yeah. But thanks for coming in. If people want to reach out, what's the best way for them to reach you?
Well, two ways. You can find me on Instagram, DocRegen, DocRegen. Or you can go to my website, palmbeachregen.com. Or if you are listening and you're like in Alaska or something like that, go to regenix.com, REGENEXX, and find a Regenix provider in your network. There's about 120 of us around the world. So,
cool.
Yeah.
That's interesting. Have to chat with them too, like, you know, some kind of that's awesome.
Yeah.
Cool, man. Well, I appreciate you coming in. We'll get round 2 on the books soon, you know. And if y'all have any questions, we're always open to questions, opinions, comments, concerns, conflicting opinions, totally. And if you have any questions as a patient, like, definitely reach out. We'd love to chat and share some insights so we can help. The best way to reach us is team@athleterc.com or our phone number at 561-889-8725. And we'll catch y'all next time.